So I think we have finished with the start to talk about cardiac output. Is that right? Awesome. There's a lot of connections over here. A lot of connections. So basically, cardiac output is the amount of blood that is pumped in 1 minute. Okay? So remember that each ventricle pumps the equivalent amount of blood. One ventricle pumps the certain amount of blood into the pulmonary circuit. Another ventricle pumps the same amount of blood into the systemic circuit. Okay? Now, think about this. It's a pump. So heart is going to contract 60 to 70 times a minute. And with each pump, it's going to eject the stroke volume. Cardiac output, by definition, is the stroke volume multiplied by the heart rate. I told you before the break that we're going to do some calculus here, like multiplication and subtraction, okay? So you increase either of those parameters, you increase cardiac output. When you increase cardiac output, what does that mean physiologically in terms of the blood flow through the tissues? Faster, more blood gets to all parts of the body. Does that make sense? That's it. So you always have to think, now, when does the tissue, or a tissue, need more blood? In very simple terms, huh? Okay, that's one. So it needs to do repair or, huh? Working out. It works. It is active. Does that make sense? So say when you're digesting, where does the blood go? Huh? Digestive. When you're working out, where does the blood go? Muscles. Does that make sense? And it depends on your needs. Like when you're digesting, basically all other activities are shut down because you're usually just resting at this moment. So this is going to be just redirecting the blood flow. But if you're working out, then your requirements in nutrients and oxygen increase massively, and that's where the cardiac output will increase. Does that make sense? So, stroke volume equals end diastolic volume minus end systolic volume. So let's talk about how you can increase cardiac output. Okay? How can you increase cardiac output? Can you increase heart rate? Yes, you can by activating which system? Sympathetic. Are we good about it? Awesome. How can we increase stroke volume? Meaning, how can we pump more blood with each contraction? There are two components to it. Look at this. Tell me. In order to increase stroke volume, what do you need to increase? No, quite an opposite. In order to increase the volume, blood pressure where? Not systemic blood pressure. This is heart. This is end of diastole. This is end of systole. How can you increase the volume that I'm pumping out? Can you increase end diastolic volume? I'm not asking mechanism, just math, just simple math. How can you make this number bigger? You either need to increase end diastolic volume or decrease end systolic. Are we clear about it? Math-wise, it's all about math now. How can you let more blood to flow into the ventricle. It's the process that doesn't happen in a split second. So if you increase the time that the heart is relaxed, does that make sense? Then more blood will flow into the ventricle. It's not unlimited. It doesn't mean that you can live on 1 beat per minute. Okay? Does that make sense? Can you do that? Also, think about this. Your blood comes from veins into the heart. If you can somehow increase that venous return, does that make sense? You increase venous return, you increase forces that bring blood via vena cava into the heart, you will increase end diastolic volume. Do I make sense? End systolic volume. That's the amount of blood that's left at the end of contraction. What do you need to do? Huh? Squeeze harder, right? You need to squeeze harder. That's one. So you increase contractility, you increase force of contraction. Does that make sense? There's option number 2. When you pump the blood from the ventricle, say left ventricle, let's talk about systemic circuit, it's just easier, okay? So you pump it out of the left ventricle. Where does it go? In the aorta? Is there blood in the aorta? Yeah. Does it have some pressure? Like, yeah. So basically your ventricle has to work against your own blood pressure. If you have lower blood pressure, like overall, normally, baseline, then your ventricle has to work against less resistance. Does that make sense? So think about this. People with elevated blood pressure, they have to pump against that higher resistance. If you ever happen to be in Houston, Texas, and let's not touch the reasons why you want to be in Houston, Texas. Great city, actually. I have a few friends living there. But if you ever happen to be in Houston, Texas, they have a great museum, which is called George P. McGovern Health Museum. Go. It's totally worth the trip. Okay? And they have a great demonstration of atherosclerosis. When they have a tube, 3 actually tubes of the same diameter. But in those 3 tubes, there is sort of an atheroma, okay? The plaque that is formed on the wall. So the actual lumen of the tube decreases. And all you need to do is to pump through that tube. They have like little hand pump. And the first one, it's fairly easy, you know. I could do it fairly easily. My kids could do it fairly easily. In the third one, I had to hang on it. I couldn't push the pump. So if person has atherosclerosis, meaning usually elevated blood pressure, you have to work against so much resistance, enormous amount of resistance. Does that make sense? So, taken overall, in order to increase cardiac output, you can either increase heart rate or increase stroke volume. And you can increase stroke volume either by increasing end diastolic volume, letting more blood to be in the heart in the diastole before it contracts, or lowering your end systolic volume, meaning squeezing as much blood as possible out of the heart. Does that make sense? Are we good? I may ask you a question, you know. I give you numbers and I tell you, okay, what if I increase heart rate 2 times, how is it going to affect cardiac output? How many times? 2 times, right? Does that make sense? So, like, you have to comfortably operate this little equation right here. Absolutely, you know. And if I will ask you to work with numbers, of course you can use your calculators. Right? That makes sense. Now, cardiac output can increase. The difference between the maximum cardiac output and resting cardiac output is called cardiac reserve. In normal folks, it's about 4 times difference, you know. So say normally cardiac output in a healthy person is about 5.25 liters per minute, which is basically the whole volume, blood volume that you have. Okay? Meaning that at the top of your performance, your cardiac output will be 21 liters per minute, 4 times more. In the athletes, cardiac output may increase as much as 7 times, which is really a lot. That's a hell of a pump. Okay? So if you would look at this table summarizes what this flow chart talks about. And we're going to now talk about the factors that affect the stroke volume. There are 3 major ones: preload, contractility, and afterload. So what is preload? Cardiac muscle has an interesting feature, okay, that the more it's stretched, the stronger it contracts. Does that make sense? Do you understand what I just said? So now think about this. Now this requires some imagination from my side as well. So you have a heart. You have cardiac muscle. And this is end diastolic volume. Right here. Case in point. So this end diastolic volume, the stroke volume will be of a certain size. Now, when you put more blood in the heart, it doesn't mean that it's going to eject the same amount. Since you stretch the heart, its contraction becomes stronger. Does that make sense? So that feature, the capacity of the cardiac muscle to contract stronger when it is stretched, allows it to eject that extra volume. Does that make sense? I want to try to explain it in a few different ways. So imagine this is the heart with one end diastolic volume, and this is the heart with another end diastolic volume. Which one is going to contract harder, stronger? The second one. So you see, this heart has to eject more blood, but it can because it is stronger. Does that make sense? Now, is this relationship like forever? You can stretch the heart to this and it will eject all? No. Look at the graph here at the bottom. So, if you stretch it to the certain volume right here, you can add more and more blood, but heart cannot eject anymore. Does that make sense? You reach the maximum force that it can generate. Does it make sense? Okay, so, but you rarely reach that point. We're good? Now, what can increase that volume? One, as we just discussed, longer diastole. If you think about athletes, their heart rate is lower. Does that make sense? Say, Alex, may I use you as an example? So, you're obviously an athlete, okay? We have basically similar body type. Your resting cardiac output and my resting cardiac output are going to be essentially the same, right? We have same blood volume. However, my heart rate at rest will be, say, 65, 70. Yours will be probably 50, 55. It means that your heart contracts not as frequent, but since it has longer diastole, it fills with more blood and its stroke volume increases. Does that make sense? Thank you very much for allowing me to do that. That makes sense? So, now, two parameters are changed. Heart rate is lower, but stroke volume, because of that lower heart rate, is higher. Does that make sense? What else can we do to fill up the heart? We can try and push more blood from the veins into the heart. Now, this is fascinating because I will need to talk about something that I'm going to talk about a little bit later. It's called, so how we return the blood from the veins. Think about this. This is the heart. Well, technically, here it is, okay? The heart. The majority of blood, where does it come from? Back to the heart. From which part of the body? The majority of the blood. Huh? The bottom, yeah. So legs, abdomen, right? It's a lot of blood that comes from here. In which direction does it go? Up. Against the gravity. What makes the blood go against the gravity? First and foremost. Yeah, your heart, first of all. Something else also. First, muscular pump. When your muscles contract, they squeeze the veins and they push the blood up like we push the toothpaste out of the tube. Does that make sense? Second, there's a respiratory pump. Have you heard about it? When you forcefully inhale, when you exercise like this, what happens to the volume of the thorax? It expands, so pressure inside the thorax goes down. What happens to the volume of the abdomen? It decreases, so pressure goes up in the abdomen. Pressure goes up here, goes down here, and the blood is squeezed from the abdomen up into the heart. Does that make sense? Okay? We got it? Muscular pump, respiratory pump, and, they will push the blood into the heart. When you exercise, your muscular pump activity goes up. We good? Your respiratory pump also, moves the heart, moves the blood much more vigorously. So when you exercise, your venous return increases. Does it make sense? So basically, your exercise increases end diastolic volume. Does that make sense? Are we good about it? Yes. This is one of the reasons. Exercise leads to change in the heart shape and so-called cardiac hypertrophy. And actually, the hearts of a weightlifter and of an athlete, endurance athlete, will have different shape. So, say a weightlifter and endurance athlete, they're both going to have hypertrophy of the muscle, but it's going to be a healthy hypertrophy. You know what I'm saying? It's not going to be myopathic. It's not going to be cardiomyopathy, thickening of the wall just because it has to work harder. Does that make sense? So that's preload. Preload basically refers to elevated end diastolic volume due to the increased venous return. Now, contractility is the force of contraction at the given length. Look at this. So this is the curve of stroke volume at different preloads. Does that make sense? So as the heart stretches, stroke volume increases. Then let's say that's how you stretched it. It can contract to this, or it can contract to this. Second time, the contractility is higher. Contractility refers to the force of muscle contraction at its given length. Now that's basically entirely sympathetic. Okay? So sympathetic stimulation of the heart increases the amount of calcium that enters the cardiac muscle. The more calcium you have, the more cross bridges will be formed between actin and myosin fibers. The more cross bridges, the stronger the contraction. Parasympathetic system has practically no effect on contractility. Does that make sense? Evolutionary, why do you think parasympathetic system would have no effect on contractility? Well, to figure it out, let's talk about what contractility, which parameter does it change? When contractility goes up, the force of contraction goes up. Which parameter in this equation is going to change? Huh? Yes. Stroke volume will gonna increase, right? When heart contracts stronger. Now, which parameter in this equation, like I'm giving you hint, which parameter in the parenthesis is going to change because of the increased contractility? And systolic volume. And how? It's excellent. It's going to go down. Does that make sense? Imagine that you're squeezing a cloth. The stronger you squeeze, the drier it's going to be in the end. Does that make sense? Now, since Lexi mentioned that elevated contractility will increase stroke volume and increase cardiac output, when do you need increased cardiac output? When does it happen? Sympathetic stimulation means what? You do what? You exercise. Well, our ancestors, million years ago, they didn't exercise. They either hunted or tried to save their ass, really. Running away from the danger, right? One of two things. So, to survive, only thing you need is to increase your cardiac output. You never need to decrease it, actually. Does that make sense? You have your resting one, you don't need to go below resting. There's no point in it. Make sense? So it's only logical that your sympathetic system will increase it and parasympathetic will have no effect on it. Does that make sense? Now, what is calcium, right? More calcium gets in the muscle, more cross bridges, stronger contraction. agents that increase contractility are called positive ionotropic agents. Thyroxine, glucagon. Well, probably not going to shoot people with glucagon, and thyroxine, but digitalis, yes. Even if you inject calcium chloride IV, that will increase heart rate. Does that make sense? Obviously, anything that decreases calcium influx into the cells will be negative ionotropic agents. Decreased blood pH, so acidosis, calcium channel blockers. Ever heard about drugs called calcium channel blockers? What do they control? Well, which physiological? So okay, think about this. If you block calcium channels, what are you decreasing? Contractility. So you decrease the force of contraction, right? When you decrease the force of contraction, which parameter will go up? And when you decrease the force, you just told me like a minute ago. So you increase the force. Wait. Think. You increase the force, your end systolic volume goes down. You decrease the force, your end systolic volume. You don't squeeze that hard. So end systolic volume increases, right? So you pump less blood out. Which important physiological parameter is going to decrease? Lower stroke volume, lower cardiac output, lower cardiac output. Do we measure cardiac output in patients normally? We do not. What do we measure? Blood pressure. You pump less blood in the blood vessels. It's all about blood pressure. You pump less blood in the blood vessels, blood pressure goes down. Do I make sense? Calcium channel blockers is the drug to control blood pressure. A little remark, it's not that good. The best drug to control blood pressure is by far diuretics, thiazide diuretics. They just reduce blood volume. We'll get to that. Okay? Does it make sense? So positive, what's the word? Positive ionotropic agents. Positive ionotropic agents. They will increase calcium influx in the cell. Negative ionotropic agents will decrease calcium influx in the cell. Due to the features of the transport across the membrane, elevated extracellular potassium will be negative ionotropic agent. It will decrease contractility. Do you know how we kill people in the United States? Potassium. Potassium chloride. So capital punishment is injection of potassium chloride together with some, sleep medicine, narcotics. And elevated blood potassium will lead to the weak contraction and actually ventricular fibrillation. Okay. Does that make sense? Now, if you would look at these two parameters, preload and contractility, you want to increase them. Does that make sense? Because, in healthy people, you usually need to increase cardiac output when you exercise, when you're active, right? Now, next parameter, you want it to be low. This parameter is called afterload. Basically, afterload is the resistance that your heart has to work against, okay? Outflow resistance. So you can see that the black curve refers to a patient without the heart failure. So as blood pressure increases and it enters the zone of hypertension, stroke volume goes down. Does that make sense? So with each contraction, your heart has to work against high resistance. So which parameter, if at the end of systole, when heart pumping blood out into the arteries, if afterload is high, which component of the stroke volume will change? If you have to push against the resistance, what's going to be affected, end diastolic or end systolic volume? End systolic. In which fashion? It will increase, yes, because it's harder to squeeze the blood out. Does that make sense? So basically, people with high blood pressure, the heart has to work against high resistance, and stroke volume will go up. And now think about this in terms of the compensation mechanisms. If the stroke volume goes up, if end diastolic volume goes up, and erase it, start over. People with high blood pressure, they have high afterload. How does it affect end systolic volume? High afterload means elevated end systolic volume. Elevated end systolic volume means in terms of the stroke volume, it goes down, right? Now, they have to maintain cardiac output at the same level. How can they compensate for lower stroke volume? They have to elevate what? If stroke volume goes down, how can you compensate? Elevate heart rate. Does that make sense? So, seriously, I told you that this whole idea of cardiovascular system is about a pump, pipes, and how you pump out more, what makes your pump less efficient, is it something wrong with the pipes? Is it something wrong with the pump? Okay. Now, inotropic agents, they regulate the force of contraction, right? Now, there are chemicals that can regulate the frequency of contractions, the heart rate. They are called, I just want to make sure, chronotropic agents. Okay? Positive and negative. So positive chronotropic agents increase the heart rate. That's going to be, say, norepinephrine. Okay? So norepinephrine or epinephrine will bind to the beta adrenergic receptors and will increase the heart rate. Okay? Calcium, so you can see that norepinephrine, does it increase the heart rate? Does it increase contractility? So it's both positive chronotropic and positive ionotropic. Does that make sense? Same goes for calcium. Calcium is positive chronotropic, positive ionotropic. Does that make sense? Now, if your heart rate goes up and your contractility goes up, what happens to the cardiac output? It goes up. What happens to the blood pressure? Goes up, right? That makes sense? So we already figured if you block calcium channels, it may help. Have you heard about beta blockers? What do they block? Sorry, they block this. Beta blockers, they block beta adrenergic receptors. Does that make sense? Now, negative chronotropic agents, basically acetylcholine. Acetylcholine will open potassium channels and will hyperpolarize the cell. So it's harder to fire for pacemaker cell. Does that make sense? Look at this. I'm just trying to find some space. So this is the pacemaker cell. Does that make sense? So this is like normal graph. What it does, it takes it farther away from the threshold. Does that make sense? So green line is the line with the, say, acetylcholine. Does that make sense? So the cell, initially, its resting membrane potential is more negative. It is hyperpolarized. So it's harder for it to fire. It's not going to fire as frequent. Okay, so what you're going to do is you're going to have something like that. Not as frequent. Does that make sense? So, potassium. Turns out potassium is both negative ionotropic, negative chronotropic agent. So when people receive injection of potassium, first of all, the rhythm slows down and force of contraction decreases. Does that make sense? We clear? Now, what do you need to know about? Those three mechanisms that influence cardiac output, I'm talking about preload, afterload, contractility. You have to know which volume is affected. So if I say, what if we just increase afterload? You tell me, well, your end systolic volume is going to go up. What if we increase venous return? Well, your end diastolic volume is going to go up. What if we increase contractility? Your stroke volume will go down. Does that make sense? We increase contractility, the stroke volume then goes down. How does it affect cardiac output? So, end diastolic volume goes up, cardiac output increases. End systolic volume goes up, cardiac output decreases. That's one. Second, chronotropic and ionotropic agents. You basically need to know a few things. So, know sympathetic versus parasympathetic. Generally, sympathetic stimulation is the positive chronotropic and positive ionotropic. Parasympathetic stimulation is going to be negative chronotropic. In terms of the specific chemicals, the ones that I want you to know the effects of norepinephrine and acetylcholine on the heart. Calcium and potassium. And pretty much we can cut at that. Okay? We good? Let's go over this flow chart, okay, to make sure that we can follow. So, when you exercise, which part of autonomic nervous system is stimulated? Sympathetic. How does it affect heart rate? Directly increases, right? Which components of stroke volume regulation does it affect? Contractility, strength of a contraction. When contractility goes up, what decreases? End stroke volume. End systolic volume. I'm sorry, I'm too long. End systolic volume. Okay? End systolic volume decreases, stroke volume goes up. Cardiac output goes up. Does that make sense? If you have, what is going to be? It's going to be positive ionotropic agent, right? Which increases contractility, decreases end systolic volume, and increases stroke volume and cardiac output. That makes sense? Now, how can you increase venous return? Two ways. One, heart rate goes down. Does that make sense? When heart rate decreases, heart has more time to fill up, venous return goes up. Or you can exercise, respiratory pump, muscle pump will increase venous return. Increased venous return means elevated end diastolic volume. Elevated end diastolic volume means higher stroke volume, means higher cardiac output. Does that make sense? Okay. More or less clear? Seriously, that equation right here, if you know what changes heart rate, end diastolic volume, and end systolic volume, few questions on the exam for sure. Okay? All right.